Today I'm going to go ahead and walk you through the different types of codes you could get tested on the NCLEX. You're also going to want to know these code terms when you start practicing as a new graduate nurse. First of all, what codes are we going to talk about? Code pink, code blue, code red, and lastly, code black. So let's start with code pink. This is going to be utilized when either an infant or a child has been abducted. That's when you're going to hear the term code pink. What's going to happen when a code pink is called is the facility is going to go into lockdown. And then the security control center is going to be notified. They're going to be calling 911. There's going to be reports. They're not letting anyone leave. They're making sure that they find this kiddo. Now, as nursing staff, what is the responsibilities? Number one, communication is key. We need to be communicating with the parents and the caregivers about the measures that we're taking. We want to make sure that visitors have their identification bands. We're going to make sure that we are reviewing what the policies are for them to be visiting. There are some different methods that we can take to prevent a child abduction from occurring. Number one, we want to provide annual trainings for all staff. And the reason why is we want to make sure that they know what things to watch out for, what things are expected, and what things are unexpected. That would be red flags that, hey, something doesn't line up here. The other thing is we do want to make sure that all workers have identification photos. If they don't have an identification photo, we do not send a kiddo with whoever that individual is. The other thing is all visitors should always be logged so we know who is here and why they're here. It is important that drills are done because we want to make sure that the staff knows what to do in case one of these were to happen. According to the National Center for Missing and Exploited Children, almost 400 infants are abducted from healthcare facilities each year. That's a lot. It is our job to prevent that from occurring. Let's do a practice question over this. The nurse comes into the client's room to check on her and her newborn child. The client tells the nurse that another nurse just came and took the baby back to the nursery. What would be the initial action of the nurse? A, alert security personnel about an infant abduction and call a code. B, ask the mother what the nurse who took her baby looked like. C, call the nursery to ask if the baby was returned to the nursery. Or D, ask the mother if she asked the nurse for a code word. Pause here while you think of your answer. If you said answer C, call the nursery to ask if the baby was returned to the nursery, you are absolutely correct. I don't want to tell the mom, hey, your infant's been abducted and start that prematurely. I want to assess where is this infant right now. Now, if we don't know where that infant is, if I call the nursery and they're like, hey, this baby's not here, then I am absolutely calling the code. I'm alerting the security personnel. And then I'm going to start asking, hey, what did the nurse look like? Did they have identification? Then I'm going to start asking those questions. But that would be too premature to start there. Answer C was correct. Here's another one. The nurse participates in a committee reviewing the hospital security plan regarding infant abduction. Which of the following recommendations should the nurse make to the committee? A, rearrange rooms so that the crib is near the door. B, carry infants in the hallway instead of using the bassinet. C, issue staff identification badges without a photo. Or D, take photographs of all visitors. Pause here while you think of your answer. All right, let's talk about this. A, rearrange the room so the crib is near the door. I don't want it close to the door where someone could just grab the infant and head out. B, carry infants in the hallway. Well, if they're being carried, that should be my red flag of, hey, this is against policy. This individual is not supposed to have this baby, which means that the infant is supposed to always stay in the bassinet. It's a great practice whenever they're outside of the room. C, issue staff identification badges without a photo. No, we want it to have a photo so we know this is the right person, they belong here. And D, take photographs of all visitors. Absolutely. This would be a great thing to recommend. And the reason why we want to recommend this is if we have a photograph of every visitor and somebody does abduct an infant, we've got a picture of them. We're going to be able to find them. Code blues. Okay. A code blue is going to be utilized when I need a team and I need them right now because we need to resuscitate the client. If a family member wants to be present, I typically will allow them to be, but I do let them know what they are going to see. When I go and start compressions on the chest, it can break the client's ribs. It can be painful. And so I do want to make sure that the family member knows what's going to be happening. Whenever I do a pulse check to see, hey, is this CPR effective? I'm only checking a carotid for about 10 seconds for an adult. The reason why is if I check for longer than that, I'm wasting time. I need to make sure that I'm circulating blood around that body into the brain so that our client has a good chance of survival. We do want to make sure that we get an AED as soon as possible, because if it is a shockable rhythm, if our client is in a ventricular dysrhythmia, their best chance of survival is getting shocked with an AED. We do want to make sure that before we provide breaths that we do a chin tilt. We want to open up this airway, because if they're like this, right, it's going to be hard for air to enter into the lungs. So we're going to do a chin tilt so that way we can get the air to the lungs. If they have a suspected cervical spinal cord injury, we don't want to actually tilt the head. So in that case, what we would do is we would actually do a jaw thrust maneuver. So instead of just doing a chin tilt like this, we're going to hold with two hands and we're going to lift the head up just very carefully so that we don't damage that cervical spine. Now, when we provide CPR, we want to make sure that we have two hands. We're going to center it on the chest so that way when I give these compressions, they are very strong. I'm going to do 30 compressions for every 2 breaths. I want to make sure that when I'm pushing down with my compression, that the chest is going down 2 inches and I allow it to recoil. If you don't allow it to recoil, your compressions are going to be ineffective. So what you want to watch is that that chest comes back up and then you push down immediately, let the chest up, push down immediately. And again, whenever we get a pulse, we're going to check the carotid. It's going to be the strongest. We're going to be able to feel it the quickest. Next, we're going to talk about code blues in infants and in children. Let's start with children because it's going to be the closest to that of an adult. Instead of utilizing 2 hands for those compressions, we're just going to utilize 1 hand to do the compressions because we don't want to force down our hands on their chest. We're going to want to make sure that hand is centered on the chest. If the child is the size of an adult, like a teenager, then we're going to go to that 2-hand method. It just depends on their size. 30 compressions for every 2 breaths. That's going to be the same. And we're going to depress that chest to 1.5 inches versus 2 like we did with the adult. Same thing, carotid artery is where we check that pulse. Now, CPR for infants looks a little different. There's 2 different methods we can use. I personally really like the 2-finger method. So if this is the infant's chest, we would utilize 2 fingers to do our compressions. You can also bring your hands around the infant and you can utilize 2 thumbs as well. There are different options. You can utilize the 2 thumbs or the 2 fingers. Now, for a single rescuer, if it's just me, 30 compressions for 2 breaths. But the second I get a second rescuer, we're going to change that to 15 compressions and 2 breaths. 15 compressions, then 2 breaths. Chest recoil is the same for that of a child. We're going to do 1.5 inches, still needs to recoil. We are going to go at about a rate of 100 to 120 per minute, and we're going to utilize the brachial artery for pulse checks in an infant, not the carotid. So what do we do if an infant has a pulse? Well, if they have a pulse, we're going to give them breaths every 2 to 3 minutes if their heart rate is below 60 and they're showing poor signs of perfusion, or if they also are showing apnea. We also want to make sure we're still calling that code blue so that we have our team ready to go and we're going to start working on this kiddo because time is of the essence. Once this infant starts to tank, they're going to tank really, really fast. Let's go ahead and do a practice question. A nurse assesses an infant with a heart rate of 50, cyanotic, and apneic. The nurse should initially what? A, start chest compressions. B, notify the code or rapid response team. C, deliver rescue breaths. Or D, obtain IV access. Let's think about this for a moment. Pause here while you think of your answer. Let's talk about this question. So it's kind of tricky, right? Are we going to start chest compressions? Their heart should be going faster than this. And so when we think about it, that's not going to be our first action. We want to notify that rapid response team. C, deliver rescue breaths. Well, we might do this. We're going to do this, but not right now. We first need that rapid response team ready to go. And then we're going to follow that 30-2 ratio or 15-2 ratio once we have 2 rescuers. And then D, obtain IV access. That is not my priority at the moment. I need that rapid response team ready to go. So as soon as we have called that code blue, that's when we're going to go ahead. We're going to start the chest compressions. After 15 or 30 compressions, we'll do the 2 breaths and we'll keep on that cycle. We will get that peripheral IV access. Ugh. But we need to make sure we do the other things first. All right, here's our next question. The nurse cares for a 7-year-old client who is pulseless. After calling in code blue, the nurse should take which action? A, give 2 minutes of CPR at a compression ventilation ratio of 15:2. Leave the client to retrieve an automatic external defibrillator, then start CPR at compression ventilation ratio of 30:2. Give 2 minutes of CPR at a compression ventilation ratio of 30:2. Or D, establish emergency IV access and prepare to administer epinephrine. Pause here while you think of your answer. If you said C, give 2 minutes of CPR at a compression ventilation ratio of 30:2, you are absolutely correct. 15:2 is going to be utilized for an infant, so we're not going to do that one. And then when we think about leaving the client, this client is in distress. We are not going to leave them. And IV access just isn't our priority. Airway and breathing come way before circulation. Answer C was correct. All right, here's another practice question. The nurse teaches a community health course on adult cardiopulmonary resuscitation. Which of the following statements should the nurse include? Select all that apply. A, the compression rate is 100 to 120 per minute. B, the compression depth should be 1.5 inches. C, allow full chest recoil between compressions. D, rotate compressors at least every 2 minutes. E, stop to check pulse every 30 seconds. Well, let's think through this one. A, compression rate of 100 to 120 per minute. Yep, absolutely. B, compression depth should be 1.5 inches. Nope. For an adult, 2 inches. Child and infant is 1.5. C, allow full chest recoil between compressions. Absolutely. That's with an infant, a child, an adult, everybody. D, rotate the compressor at least every 2 minutes. Yes, we definitely need to be rotating every 2 minutes. And lastly, E, stop to check the pulse every 30 seconds. We don't want to stop CPR every 30 seconds. The chance of survival goes dramatically down if we're stopping that often. So instead, what I would want us to do is to assess the pulse every 2 minutes when we're changing out who's doing compressions and who's doing the respirations. A, C, and D were our correct answers. Nice job. Next, we're going to talk about Code Red. Code Red is going to let everyone in the hospital know there is a fire or there's a smoke emergency. Really, we need to prioritize getting clients away from the fire. So how do we do that? Well, we're going to utilize RACE. Rescue anyone that's in immediate danger, then we're going to alarm. We want to let everyone know this fire is happening. Then we're going to C, contain. So any doors, we want to close them. We want to make sure the windows are closed. We also want to shut off any oxygen sources because oxygen is very flammable. So if that flame hits that oxygen source, it's going to combust. And so we want to make sure we have contained it. And then lastly, E, extinguish. Attempt to, put out a small fire if it's safe, but if it's a large fire, get away from that fire and evacuate. Now, when we evacuate, number one, we're going to get anyone who's closest to the fire away, but then we're going to start with the ones that are the most independent, the ones that can get away on their own, and then we're going to work our way to the clients that are the most dependent and are going to take the most resources. If you do go to extinguish, I want you to utilize the PASS acronym. Pull the pin, aim at that base of the fire, squeeze the handle, and you're going to sweep from side to side at the base of the fire. Here's our practice question. The nurse is caring for assigned clients. Which client should be evacuated first during a fire? A client with A, a below-the-knee amputation receiving patient-controlled analgesia. B, acute respiratory distress syndrome receiving mechanical ventilation. C, advanced dementia receiving internal feedings and intravenous fluids. Or D, acute glomerulonephritis with an indwelling urinary catheter. Pause here while you think of your answer. For this question, I'm thinking which client is the most independent? The most independent client here is option D. If you chose option D, you got it right. Nice job. And the reason why is this client is the most ambulatory. All right, here's another question. The nurse observes sparks fly from a client's bathroom light. Which action should the nurse take first? A. Obtain a fire extinguisher. B. Close the bathroom door. C. Remove the client from the room. Or D. Activate the fire alarm. Pause here while you think of your answer. If you said C, remove the client from the room, you are absolutely correct. We're going to utilize our RACE acronym: rescue, alarm, contain, and extinguish. Here's another practice question. The nurse observes that a fire has ignited in the client's room. After removing the client from the room, the nurse should then A. Activate the fire alarm, B. Extinguish the fire, C. Contact the nursing supervisor, or D. Close the door to the client's room. Pause here while you think of your answer. Let's use the RACE acronym: rescue and then alarm. So we need to A. Activate that fire alarm. Nice job. And then lastly, we have what's called a code black. This is going to indicate that there is a current bomb threat within the hospital. We have specific responsibilities as the nurses in these scenarios. Individuals that are trained are going to make sure that they are searching for anything suspicious that could indicate that the individual has a bomb. If there is something suspicious found, you leave it. You don't touch it. You're not going to do anything with it. You leave it there until a specified team comes to assess. We do have to make sure that there are specific and clear roles that are assigned. Someone needs to be in charge of crowd control. Someone needs to be in charge of patient care. Someone needs to be the liaison with external agencies like the police force, like the bomb squad. So we have to make sure we've assigned out these specific roles. And lastly, communication needs coordinated. So a lot of times we're going to utilize some type of internal system because there is a chance that there's some type of trap set on external systems. Walkie-talkies are a great option for this, and they're generally going to be safe because they can't be hacked. Now, if there is a code black, outpatient procedures, non-emergency procedures, they're going to be deferred. They're going to make it where ER patients aren't coming in. They're going to defer them to the next hospital. Awesome job, future nurses, going through the different codes that you're going to want to know as a new nurse. If you have any questions, you're always welcome to email us at nclextutors@archerreview.com. Bye, everyone.